Okay, pharm considerations. Let's talk for a few minutes about some different pharmacology concepts. And we'll talk about some peaks and troughs. We'll talk about some different drug therapeutic levels and toxicities. And then we'll talk about when to give and hold medications. Now, for peaks and troughs, why do you draw a peak or trough level? Well, you draw them for drugs that have a narrow therapeutic range. Okay, so for drugs who have a narrow difference between the minimum effective dose and a toxic dose. Okay. So if a drug has a really wide therapeutic range, that means that the difference between when the drug starts to work and when it becomes toxic is really wide. It's really far apart, those two doses. And you need to understand the timetables for peaks and troughs. And it doesn't matter what the drug is. It just doesn't matter. It's indifferent to the drug. So the timetable is important, though, for the route. Okay. So for sublingual, you're going to draw you want to draw the trough level 30 minutes before you give the next dose, and it's going to be peaking 5 to 10 minutes after it's dissolved. Okay. So that's for sublingual. For an IV dose, the trough is going to be 30 minutes before the dose, and the peak will be 15 to 30 minutes after the drug is finished being administered. Okay, so IV is 30 minutes before or 15 to 30 minutes after. For IM, the trough is going to be drawn 30 minutes before the dose, and the peak is going to be drawn 30 to 60 minutes after the dose is given. Now, for subcutaneous, the trough is going to be drawn 30 minutes before, and the peak is going to vary by the drug. That's the one exception. So for that one, listen to the diabetes lecture, because really that's the only time that the peak matters in a subcutaneous drug. Particularly on the NCLEX. There's other exceptions, but for the NCLEX, that's what you really need to know. So for subcutaneous, the trough's going to be 30 minutes ahead of the dose, and see the diabetes lecture for the peak levels on subcutaneous. Now for PO doses, the trough, 30 minutes before the dose, and the peak is not going to be asked. Why? Because there's just a huge range all over the map. All right. So what I want you to notice, the trough levels, same for all of the different routes. Okay. 30 minutes before the dose. The peak is going to escalate from 5 to 10 minutes for sublingual, 15 to 30 minutes for IV. For IAM is going to go 30 to 60 minutes. For subcutaneous, just watch for diabetes and don't even worry about the PO route for the peak levels. Okay. So what if they ask you a question about when a drug will be peaking and they give you 2 times and both of them seem pretty close? Which one are you going to pick? Okay. What you want to do is, if 2 answers are within the range, you want to select the one that is highest without going over whatever the normal range is for that drug or that route. Okay. So for a client who, say, takes sublingual nitro, and I ask you at what time will the drug be peaking? Will it be peaking at 7 minutes or 9 minutes? Which one would you select? Well, they're both in the range, right? So you want to select the highest one without going over. And the reason is, typically drugs will have a quicker onset, and then they'll trail off slowly. So if you look at the little example here where you have 0 minutes, then you have 15 minutes, and then 30 minutes, and the drug's peaking, it looks at, say, what's that look like, 26 minutes or so? If you go 15 minutes and that's in the range, the drug hasn't quite reached its peak yet, and it's still going up quickly. But once it does reach the peak, it starts to go down slowly. So at that 30-minute mark, still may be within the normal therapeutic range, but is just past that peak point, and it's going to be a more accurate indicator. So if 2 times are within the range, 2 answers are within the range, then select the one that's highest without going over. Well, what about some toxicities and therapeutic levels for different drugs? There's 5 of them that you may be tested on, and one of them is not even a drug. But for lithium, which is used to treat mania, the therapeutic level is 0.6 to 1.2. 0.6 to 1.2. So the low end times 2, and it quickly becomes toxic at 2.0 and above. So that's a very narrow therapeutic range, right? For Lanoxin, also known as Digoxin, Digitorum, Digitalis, you'll see it as any one of those 4, right? You're not going to see it be given by or listed by both names or 2 of any of those 4 names. You'll see any one of the 4. And that's an exception on the NCLEX. Typically, they'll give you the generic name and a brand name. But for Lanoxin, you're going to have to know it by Lanoxin, Digoxin, Digitalis, and Digitorum. Therapeutic level is 1 to 2, and it's toxic at 2.0 and above, obviously. Aminophylline, which is a drug to be in asthmatics. It's an anti-airway spasmodic or an airway antispasmodic. And that therapeutic level is 10 to 20. And it's toxic above 20. Dilantin, which is anti-seizure medication, has the same therapeutic level as aminophylline, 10 to 20. And the toxic level is 20 and above. And then bilirubin, if it's in 10 to 20 range, that's okay. But 20 and above is toxic. Okay. And if it's above that, it can cause kernicterus, which is a neurologic dysfunction. So I put it in here because if you look at this, for the toxic levels, all basically look like 20. You got a couple of 2.0s and then 3 20s. And you will also notice that the therapeutic levels have lots of 1s and 2s in them. So look at that and make a mental image of that table so that you can see the different therapeutic levels and toxic levels. Well, what happens if you have a drug that ends up being in between those 2 ranges? So say for lithium, for example, you get the lab values back and it says that the lithium level in your patient is 1.4. What do you do when that drug is due next? So say that drug's due right now and you just got the labs back, say that the level is 1.4. It's not toxic range, right? What do you do? And what do you give the drug or do you hold it? So you give the drug if the level is over the therapeutic level, the toxic range. And then you call the doctor. Okay. But you hold the drug if the level is over the therapeutic level, and then you call the doctor. Okay. So give the drug if it's over the therapeutic range but under the toxic, and hold the drug if it's in the toxic range, and then call the doctor. All right. So this is just some basic considerations for pharmacology concepts. I know I breezed through that kind of quickly, but this is kind of some straight up content-based stuff. But you'll see there are some patterns to the information. So we use peak and trough levels for drugs that have a narrow therapeutic range, and the timetable does not matter based on the drug. It's more route specific. So the troughs are drawn 30 minutes ahead of the dose, and then the peak is going to vary based on the route. And if the question asks you about peak and trough, and there are 2 answers that are within the range, the normal range, then select the one that is highest without going over. Okay. Make sure to make a mental image of the toxicity levels and the therapeutic levels for the different drugs. Make sure you know lithium especially and the Lanoxin, because those are the 2 that most other new graduate nurses are going to know. You don't want to miss those questions on the NCLEX, because most other new graduate nurses know those answers and know about those drugs. That makes them easier level questions. And so if you're missing easier level questions on the NCLEX, that's not a good sign. Okay, so we want to make sure we're getting the easy questions right. So know lithium and Lanoxin especially. All right. So that wraps up pharm considerations, and good luck.